Yep.
Recording in progress.
All right. I'm just making sure it's working good. All right. Good evening. So, basically, I'm not going to take your time because I know you guys got to go study. And I hope you guys are ready for the exam tomorrow. As I said before, I've given you guys enough time for this exam. I really think so. Take your time. Don't rush the exam. I think some people are going to finish a little early. I think some people are going to take a little time to finish. If you study really hard and you know the material very well, I think you'll finish early. If you don't, and if you think you just memorization is not going to help you out on this exam, unfortunately, because again, this exam is testing your knowledge to make sure you understand the material. Endocrine is a lot of information on there on the exam. I think it's about 38 or 39 questions, even 40 questions, I think. Can't remember exactly. And the woman health, maybe I think 8 questions, and endocrine, a lot of questions on that, maybe 10 or 11, can't remember. Geriatrics is about, I think, 11 questions. So pretty much the total questions on the exam is 65, but endocrine is the everyone, that is on the exam. And that's why I dedicated my time on Friday to review it. And I sent it to you guys. And I'm just going to go over some things that I think, I want to reinforce. People ask me this question through email. So I want to reinforce that real quick. So if one or two people ask me the same question, that means the entire class needs clarifications. I'm going to go over that real quick when it comes to the endocrine. So the first I'm going to talk about is that when you have a patient that's got a weight gain, right? So what are the possible diagnosis? Again, this is the way you're going to be answering the question on the exam on tomorrow. You're going to see a buzzword and you got to, associate that buzzword to some kind of pathology. So for example, if I say a patient is gaining weight recently, what are the conditions that could make a patient gain weight? Okay. Anyone?
Hypothyroidism.
Right. Keep going.
Well, you get
Cushing.
something
Diabetes.
with Cushing's.
Okay. Keep going. All right.
Diabetes mellitus.
So basically, I did that on purpose. I mean, you see the answer here. That's the answer right here. But again, what I want you to do on the exam, okay, even for your board exam in the future, is looking for the buzzwords. Weight gain. Think weight gain. Think of hypothyroidism, diabetes, Cushing's syndrome, obesity, right? So think about all that, right? Then the next thing you're looking for is what other words are in the question stem that could help you or guide you towards the answer. Okay. So, for example, if I say the patient's got a weight gain, right, and they're hairy body, abdominal striae, a moon phase, what's your diagnosis?
Cushing's.
Right. You see what I just did there? On the exam, right? You're not going to get a straightforward question like that, right? Just like second, third order, right? They're going to say the patient is gaining weight. This got moon phase, this got abdominal striae, they got a hairy body, right? And they'll say, what's the best treatment? So the first thing you have to do is to come up with a diagnosis, right? Then you come up with the answer with the treatment for the patient. So you're going to get a lot of questions like that. Again, this exam is very straightforward. If you understand the material, you'll get the question, boom, 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 you'll be done in, I'll say, in an hour. But if you do not understand the material, you just memorize, you will be lost on the exam, and I promise you're going to fail. So let's just do a couple of exercises here. So what about patients who's got a polydipsia, polyuria, and thirst? Okay, and they have recent weight gain. What are you thinking?
Type 2 diabetes.
Right, type 2 diabetes, right? You have to remember it's on the diabetes without weight gain, though, that will give you polydipsia, polyuria, and thirst. And what is that?
Are you referring to type 1 diabetes?
Insipidus.
I mean, type 1 diabetes can do the same thing. I get it. Which one?
Gestational diabetes.
Diabetes insipidus.
Thank you. Diabetes insipidus. Okay, when you say diabetes, I eat diabetes. That covers all the diabetics. Diabetes type 1, type 2, gestational, who cares? It covers that, right? I'm talking about what other diabetes will also lead to polydipsia, polyuria, and thirst. That's diabetes insipidus. That's another one, that will lead to that. And how do you treat that? How do you treat diabetic insipidus?
Give them fluid.
Okay.
If it's nephrogenic, then you can give them ADH.
So somebody say fluid, somebody say, give them, ADH. What's the other name for ADH?
Vasopressin.
Vasopressin. So my question is, how do you treat a patient with diabetic insipidus?
With a vasopressin.
Well, somebody said fluid.
I know, but they're getting rid of fluid, so you wouldn't give them fluid. You want to give them something that will keep the fluids in, which is vasopressin.
So Jill, are you correct or that person is wrong?
Well,
You're correct. Just say you're correct.
I'll say I'm correct. I mean, you could have issues where because they are excreting so heavily and you don't have some kind of balance, they could also become dehydrated, I would imagine. So then in that case, you might need fluids, but the only way to keep the fluids in, if you give them fluids, is to also treat with the vasopressins.
Right. You said that's a really great point. So diabetic insipidus, if you give me fluid, guess what's going to happen to the fluid? Gone, out, done. So it's not going to stay. So the first you want to do, you want to correct it by giving them vasopressin. So once you give them vasopressin, all right, then what's going to happen is that, you're going to retain your fluid. Then you can even give them more fluid if you want. Okay. But the first thing you have to do, you want to stop, the loss of fluid in the urine, in the kidney. So vasopressin is the answer. Okay. And basically, if you have a patient that is losing urine, like losing water like crazy, and you give them vasopressin, and that stops or is corrected, that means you're dealing with central diabetic insipidus. Okay. And if you have a patient that's got a, kidney problem, it doesn't matter how much vasopressin you give them, nothing's going to happen. So you got to treat what's causing that problem. So what are the three, medications that I talked about yesterday that could lead to a patient developing nephrogenic diabetes insipidus?
Lithium, amphotericin, glyburide.
Keep going. Small.
Colchicine.
That's right. Exactly. So basically, with nephrogenic, so if you just take away the medication, guess what? It's auto corrected, right? So a patient that's got that's got a kidney problem, you give them vitamin D and you give them some ACE inhibitor, and you notice that their condition is getting better and they stop losing water. So that means the patient has some kind of nephrogenic diabetic insipidus. So again, you got to be careful and see, where the question is taking you. Now, when it comes to diabetes and diabetic insipidus, both of them have the same symptoms, but we're going to guide you and say, this patient has a low ADH. So okay, you're talking about diabetic insipidus. So we'll give you more clues. Just pay attention to the clues. Next one, patient has a partial thyroidectomy. So what do you think might be the cause of the weight gain?
Hypoparathyroidism.
Exactly. Okay. Or guess what? Another thing is basically a patient that is getting partial thyroidectomy might be that they have what? Solitary tumor or multinodular goiter or multinodular lesions, okay, on the thyroid. And basically you wanted to remove, that part of the thyroid. So your thyroid two parts and divide into two. So guess what's going to happen? You're going to produce less, thyroid hormones. So you're going to get hypothyroidism. Okay. So again, you got to be careful with that. Also, with this patient that's got a partial thyroidectomy, you're going to get hypoparathyroidism also. Okay. This is what this exam is going to do to you tomorrow. Make you think. Give you a scenario, think. Give you a scenario, think. Does that make sense what I just did? Like partial thyroidectomy could give you hypothyroidism. Partial thyroidectomy could give you hypoparathyroidism. Agree?
Yes.
Okay. What about this one? Truncal obesity, high BMI. What's causing the weight gain?
Obesity.
Obesity, right. What about this one? Hair loss, cold intolerance, very tired, very weak, very
Hypothyroid.
Hypothyroid.
Exactly. Again, you guys got it. Again, you guys see what I just did? Again, that's what we're going to be doing tomorrow. Again, my thing is when I do a review, I just don't want to, I don't like the fact that we give an exam, give you a handout and go read it and take an exam. I like to make sure we discuss it and see which areas it's a little difficult to understand, which concept need more reinforcing, that I don't want you to forget ever because it's so important. And that's what I'm going to do today. The next one here is you have a patient with weight loss, walk across weight loss, right? We know that hyperthyroidism will cause you weight loss. Addison's disease will cause you weight loss. Hypopituitarism will cause you weight loss. Pituitary apoplexy will cause you weight loss. Pheochromocytoma will cause you weight loss, right? The question is, which one are we dealing with on the exam? Let's do it together. What if I tell you you have heat intolerance, tachyarrhythmia, and tremor? What's your diagnosis?
Hyperthyroidism.
Hyperthyroidism.
That's right. That's right. You have bilateral non-pitting edema with shining pretibial in the shining pretibial area.
Hyperthyroidism.
And what's the diagnosis? What's that thing called?
Graves. Oh, pre-tibial myxedema.
That's right. And we see that in hypothyroidism and Graves. Great. Awesome. What about this patient? Tachyarrhythmia. Remember, tachyarrhythmia. Hyperthyroidism and pheochromocytoma. They are so close in symptoms, so close to the point that you need to just focus and find out what exactly they say in that question stem. Or you're going to miss them up. So be careful. You're going to see pheochromocytoma, and you're going to see hypothyroidism all in one shot. You better know exactly which one they're telling you, and they'll give you clues. So tachyarrhythmia with increased urometanephrine. What's your diagnosis?
Pheochromocytoma.
And where do you, what organ causes pheochromocytoma?
The
Adrenal
medulla.
Adrenal.
Adrenal what?
Medulla.
That's right. That's right. Okay, you have let me just go to the next one. You have a low ACTH, low luteinizing hormone, low MSH, low FSH, low everything. What's your diagnosis? Oops.
Addison's.
Hypopituitarism.
What is it?
Hypopituitarism.
Hypopituitarism, or it could be pituitary apoplexy. Agree?
Yes.
Okay. What about this one? High potassium, low sodium, low BP, low glucose, low. The one thing that is high is potassium. What's your diagnosis?
Addison's.
That's right. Good job. Okay, the next thing I want to discuss that I think people always make a mistake, and I think if it wasn't properly explained to you, you're not gonna get it. Okay. When it comes to hypo and hyperthyroidism, okay, the most important thing is to get a really good history and physical. The reason why that's so important, for example, hypothyroidism, if they tell you, this patient will tell you, oh, I have this big mass, my neck, I just came from a third world country, unfortunately, we don't have iodine in that country, whatever. I'm just making things up, okay? What is that telling you, right? That you have hypothyroidism causing goiter due to low iodine, right? So that history and physical is so important when it comes to differentiating between these thyroid problems, right? The next thing that is so important after you've gotten your good history is you always want to start with your TSH. Let me repeat. To differentiate between hypo and hyperthyroidism, you always want to start with your TSH. After TSH, you want to go and find out what's going on with the thyroid hormone, the T3 and T4. After that, if you can't find your answer, then you want to go ahead and order your anti-TPO. Okay? And once you're getting close, you want to confirm the gold standard or the imaging modality or the gold standard to diagnose a patient with the thyroid problems, do ultrasound of the neck. That's a gold standard. You could add MRI to it. You could add CT scan to it. And the last thing you want to do is to do a thyroid scan. That's the proper algorithm in diagnosing hypo and hyperthyroidism. Any questions? Are we good?
Yeah, you just want to quiz us on which, like what combination we would find, with the TSH and the T3, T4 in terms of differentiating between the two?
What I'm saying is, if you want to differentiate between hypo and hyper, you start with H&P, then you check your TSH first.
I know that. I'm saying, do you want to give us some scenarios so we can tell you if it's
Oh,
hyper or hypo, or or if it was due to the hypothalamus?
okay, good, perfect. Okay, let me give you an example. Got it.
Yeah.
Okay, you have a patient that let's just say you have a 46-year-old female with cold intolerance, heavy menses, is gained weight recently. What am I trying to tell you?
Hypothyroidism.
Beautiful. Now that hypothyroidism, we want to find out, okay, even though from the history we know exactly we're doing with hypothyroidism, you're going to order everything together, but the first you want to check is what on your blood test? What hormone?
TSH.
TSH.
Exactly, that's what I'm getting at. Check your TSH. And what you're looking for, you want to make sure you're dealing with hypothyroidism, right? So what's going to happen with TSH? Increase or decrease?
Increase.
Exactly. Increase. Okay. Then after you're going to go and find out what's going on with my T3. Okay. Your T3, increase or decrease?
Decrease.
Decrease.
That's right. Decrease. Exactly. At that point, okay, even though this is a primary hypothyroidism, okay, that could also be caused by an autoimmune disease, okay? So to just make sure you're not dealing with, I don't want to mention the name, what's the name of that, autoimmune disease that could lead to hypothyroidism? Hashimoto, right? So you want to make sure, maybe I have a little bit of Hashimoto going on too. Then you want to order your anti-TPO. If that's negative, you'll stop, you're done. Case closed, you're doing what. And if you want to walk this patient up more, you can order ultrasound, do an MRI, CT scan, thyroid scan. That's if you want that confirming, heavily confirmed. But based on this study, once you get your good history, you follow up with the TSH and T4, and you realize your Hashimoto, at that point, you kind of got your information, what you're dealing with. Sometimes, you want to prep the patient for surgery. Maybe they have a mass, due to hyperthyroidism. Then you want to get your ultrasound, you want to get your MRI and thyroid scan to plan for surgery or for biopsy, But most of the time, the diagnosis is pretty much straightforward with the H&P, TSH, and T3 and T4. Okay, any questions?
Thank you.
No problem. Okay. Next one, this is another one that's crazy. I think we need to really break this down. So what I'm doing today, just breaking down concept that I think is just a little crazy, so you guys understand it, okay? And the rest of them, it's just straightforward. Everything is straightforward. So the next one we'll talk about is serum osmolality. Okay, when you hear the word osmolality, think of concentration. If I say serum concentration, that means this concentration within the serum is high. Okay, so if I say increased osmolality within the serum, that is increased concentration. So anytime you hear osmolality, think of concentration. Okay. Now let me give you something very simple here. Again, it depends on female, male, young, adult, whatever. But again, the average normal urine and average urine and serum osmolality, the average, I say average now, it could be 275, it could be 289, it could be 30, whatever. But the average usually is 300. So I use that word 300, right? So anything above that 300 is considered, concentrated or increased osmolality. Anything below that is considered, decreased osmolality. Okay. So that's kind of the way, you want to think about this. So for example, if you have a patient like this that's got a serum osmolality of 400, okay, is the serum concentration increase or decrease?
Increased?
Increase.
Yeah.
So if you guys remember, in my recording, there was also in the class capture and handout from whatchamacallit, Dr. I can't pronounce it, Dr. B. And they say, serum, sodium increase. Remember that arrow, that chart, serum increase, then serum sodium increase, and serum osmolality increase, and and also urine osmolality. So if you remember that, I also just not memorize, just at least understand that concept and remember that. So what I want you to do on the exam is to draw your arrow up, down, up, down. Up meaning that it's concentrated, down means like it's not concentrated. So let's do it together. So serum osmolality of 400, that means it's increased. So I'll draw my increased arrow. Serum is increased. Okay. Urine, okay, of 1,000. Okay, that is also what?
I would say
Increase. Okay. What condition gives you increased concentration within the body and also increased concentration in the urine?
Dehydration.
Dehydration. Oh, look at that. There you go. Very straightforward, very easy. Okay. What about this patient? Serum osmolality is 1,000. So you draw your arrow, increase, right? Urine concentration or osmolality is 100. So that's decrease. So the question is, what condition will cause your urine to be diluted? Okay. But will cause your serum concentration to be increased.
Diabetes insipidus.
Ah, you are so smart. Let me stop here. Listen, this concept is so hard to understand. Okay, I want to make sure you guys get this. Any question? No question. Good.
I have a quick question. Are
Yeah.
we going to be given the normal values, or do we need to memorize those?
I don't remember, to be honest with you. Again, I didn't make this question, so I didn't make this question, so I don't remember the question actually. I don't remember. But I'll recommend, again, use that. This is what I use for me. I use 300, and it's really has worked for me. I have to use 300.
Okay.
If you're given, I'm not sure if it's, I don't remember. I'm too busy. I didn't.
Yeah, that's fine. If 300 is what we need to know, then
Yeah.
thank you.
No problem. Okay, what about this one? Serum osmolality is 1,000. Urine is 100. Okay, what do you have? We said it before, diabetes insipidus. We got it, right? Yes, I'm good. Then you give this patient vasopressin. Now the urine concentration is 300. It's normal. What's your diagnosis?
Central diabetes insipidus.
Oh, you're the smartest. Who's that? Who's talking?
Taylor Furtado.
Oh, Taylor, how you doing?
I'm good. How are you?
Oh, very well, very well. Good, excellent, Taylor. What about this one? Serum osmolality, 1,000, same patient, diabetes insipidus. After you're giving the patient vitamin D and ACE inhibitors or ACE therapy, the urine normalizes or increases. Okay, what's your diagnosis?
Nephrogenic.
What if you have the same patient, okay, and this patient is on amiodarone and colchicine, and you stop those medication, and then the urine concentration goes crazily high? What's your diagnosis?
Drug induced.
Thank you. You guys see what I just did there? That's the way I want you guys to start thinking on it. This exam, again, is very straightforward. If you understand the material, right, I 100% promise you, you're going to do really well. But if you memorize, you're going to fail. I'm telling you. It tests your knowledge, tests your thinking. Okay. The next one is, what is this? What am I saying here? Diabetes equals increase. Oh yeah, I remember. So basically, can you mention medications that you could use to treat diabetes? And this medication will help you lose weight. And also this medication will help you, protect your heart, your kidney, prevent stroke. Anyone?
GLP-1 inhibitor and SGLT2.
Beautiful. Excellent. Come on, where are you? Not working. Okay, good. Any problem with that? Anybody good? Okay. So I discussed this aggressively, you know, that there are companies that wants to make money because everybody's going crazy, you know, about Ozempic because they're using it to lose weight. But again, Ozempic is not for, you know, someone that's non-diabetic. It's for diabetic people. People that are non-diabetic are using it. So guess what happened? You know, companies said, wait a minute, how can we make money? So the same content, you know, semaglutide is in Ozempic, is in Wegovy, is in Rybelsus, right? So now they market this Wegovy as, oh, this is only the one for losing weight. So if you're not diabetic, don't worry about it. Just use Wegovy and you lose weight. So it's like a money's to make money, whatever. So anyway, so basically when it comes to your GLP-1, okay, these two right here, Wegovy and also Sasenza, those two are only for losing weight only, not for diabetics. Okay, and this right here, your sodium glucose co-transporter, okay, they are used, okay, in also treating diabetes and weight gain and also losing weight. Now, there's another one that I talked about. This is what I was just talking about. You know, that just make sure Ozempic is for, you know, diabetes and losing weight, while Wegovy just strictly for losing weight. But guess what? They have the same. Look at this. The same ingredients. They just did it on purpose, just to pass it through FDA to make good money. That's what I think, to be honest with you. Whatever. Hey, there's another one. Just like you have your semaglutide, where you have Ozempic and Wegovy that's marketed different. There's another one. So you have, you know, the give me 1 minute. You have the GIP called the glucose dependent insulinotropic polypeptide, which is combined with your GLP-1, right? And this when you combine it together, so they contain this thing called the zopaptide. Okay, zopaptide actually, that content alone actually has been shown to help you, you know, control your diabetes and also lose weight. So the brand name that we have out there is Zepbound and Mounjaro. Okay, well, guess what? Mounjaro was marketed for diabetes and obesity, for both, right? Whereby Zepbound was only marketed for obesity. Okay, even though both could treat diabetes and obesity, but again, they market it, you know, as Zepbound as the only one that could, you know, help you lose weight, you know, not to treat just diabetes. So basically saying that you could use Zepbound, okay, pretty much in non-diabetic. So kind of same thing as your, you know, Wegovy and Ozempic. So same thing with this one, you know, when it comes to your Zepbound and Mounjaro is used to treat diabetes and also to lose weight, whereby Zepbound is used to strictly to lose weight. But you could use both actually to treat diabetes and also to lose weight. But when it comes to last year, I think it was 2023, that's when Zepbound was approved for just losing weight. So, you know, just wanted to bring that up. Any questions? It's very confusing. For me, when I was reading about this, I was so confused that it was the same name, you know, what's going on? And to find out, you know, different company market it, you know, differently to make sure that people that are going crazy about losing weight, you know, they'll say, well, I'm not diabetic, you know, that's you're not diabetic. I can't give it to you. I can't give you Mounjaro because you're not diabetic. So they came out with Zepbound, and basically now, if you're not diabetic, you use this medication to lose weight. Any questions? Are we good? Did I lose you guys?
We're good.
Okay, so yeah, you know, I was a little confused myself when I was studying this months ago, you know, then I did my research. I found exactly what's really going on. So Zepbound for obesity, Mounjaro for both diabetes and losing weight. Whereby, okay, this is acting up. Same thing with this one, Ozempic, diabetes and losing weight. Wegovy only for losing weight. Okay. The next one I want to talk about is, what is your diagnosis? What am I trying to say here? Okay, you have a constant bone breakdown and remodeling. Just by saying it alone, what's your diagnosis?
Paget's.
Exactly, Paget's, exactly. All right, with Paget's, what's going to get? You're going to get bone pain, bow legging, You're gonna get hypercalcemia. Sometimes it might be normal, but the most important thing is that you're gonna have severely increased alkaline phosphatase. Can you tell me endocrine conditions that could lead to increased alkaline phosphatase?
Osteomalacia or rickets.
Okay, that's number one. Beautiful.
Hyperparathyroidism.
Hypoparathyroidism. Beautiful. That's number two. Good. And your Pagets, right? Pagets. Okay, those are the three that will give you increased alkaline phosphatase. That is,
Also liver disease, right?
what is it?
Liver disease.
I'm getting, that's why I'm going there. Thank you so much. Right, liver disease will also give you elevated alkaline phosphatase. Okay, now the question is, how do you differentiate between someone that's got a Paget's disease and liver disease? Anybody know?
GGT. Yes, I'm
That's right, GGT. You got it. Come on. GGT. So basically, GGT will be severely elevated in liver disease. So in liver disease, you're going to have an increased GGT and increased alkaline phosphatase, whereby in Paget's, GGT will be normal. Okay. What is the treatment for Paget's disease?
Bisphosphonates?
Bisphosphonate. Keep going.
Calcium.
Calcium. Keep going. What about this thing?
Satonin, maybe.
Bone pain. What do you do for bone pain?
NSAIDs?
NSAIDs, pain medication. That's right, pain medication. Okay. Remember, you are constantly breaking down bone. If you're constantly breaking down bone, you are releasing calcium and phosphate, right? What hormone will prevent your constant breakdown, pretty much prevent osteoclastic activity?
Calcitonin.
Huh?
Calcitonin.
Calcitonin, thank you. True or false? I could use calcitonin to treat Charcot deformity, acute Charcot deformity.
True.
That's right. Good job. You got it. Pain control, vitamin D, calcium, bisphosphonate, and calcitonin. Okay. Another student asked me this question. I'm just going over the things that someone asked me, right? I want to make sure you guys get this, so I'm going over real quick. Another student asked me was, how do you differentiate between Down phenomena and Simoji? Let me make it very simple for you. Down phenomena, okay, at 3 o'clock in the morning, your growth hormone is actively involved because the growth hormone wants to build, wants to repair. So unfortunately, the function of the growth hormone is also to release sugar, glucose. So basically at 3 o'clock in the morning, you're going to have hyperglycemia. Okay, at 3 o'clock in the morning due to growth hormone. Okay, and that hyperglycemia will remain till 8 o'clock in the morning. So when you check the blood sugar for a patient who's got a Down phenomena, at 3 o'clock, they're going to have hyperglycemia. At 8 o'clock in the morning, they're going to have hyperglycemia, right? And I'm going to tell you why, it's so important, diabetic patient, in a minute. Just give me a minute, just to understand in 1 minute. The next one is, I won't tell you the name now. I want you to tell me the answer. The next one is this condition called, I'll tell you, called Simoji effect. With Simoji, what happened is that, actually, you see it's actually in diabetic patient. What happened is that at 3 o'clock, they have hypoglycemia. Because of the hypoglycemia, the body is in stress, so stress hormones are going to be released, and you're going to have what? Your glucagon, your epinephrine, your cortisol, and everything's going to be released. And that will cause hyperglycemia. So when you do their blood test in the morning, they're going to be hyperglycemic. Okay. So when it comes, any questions so far? We're good? Now, when you want to tie that to diabetes, okay, okay, with Down phenomena, remember at 3 o'clock in the morning, their sugar is extremely high at 3 o'clock in the morning. What will you do for that patient's insulin before they go to bed?
Increase.
Exactly. Increase it. People with Simoji effect, that means at 30 o'clock, they have hypoglycemia. What will you want to do, okay, for their insulin before they go to bed?
Decrease.
Decrease it.
Exactly. Have you ever seen a patient come to your office or in the clinic saying, when I wake up in the morning, my sugar is normal, but at night, it's just so low. Okay, so that's kind of Simoji effect, and what you want to do, you want to reduce their insulin, and that'll kind of balance itself. That's how you kind of connect that, with your diabetes. So, Down phenomena is caused by GH, right? Whereby in your Simoji is caused by your stress hormones. Okay, when you tie it to diabetes for Down phenomena, you wanted to increase the insulin, and when it comes to your Simoji effect, you want to decrease the insulin. So a student asked me that question, so I thought I should go over it real quick. Any questions? So those are the questions that the student you guys asked me, and I went over that, and I hope that answered your questions. So I'm gonna go to my next one. I'm struggling here to get this thing closed. Close, save. It is very slow. Not responding. Serve my life. Stop sharing. The next I'm going to go into is nephrology. Let me share my screen. Okay, before I go to nephrology, did I explain everything very well for endocrine? Are we good?
Yes.
Okay,
Yeah, we're good.
So the next one here is your nephrology. You'll be quick. So for this nephrology, I think it's about 11 questions, I think. What you want to know is what is AKI, CKD, okay? When do you need dialysis? Hyperkalemia, what do you see on the EKG? How do you treat it? Polycystic kidney disease, nephrotic syndrome, and kidney stones, how do you treat them? So when it comes to acute kidney injury, basically what's really happening is there's a sudden, or acute reduction in the kidney function. So what you're going to see low GFR, you're going to see oliguria, low urine output, and you're going to see increased nitrogen waste, meaning that your BUN, your creatinine is going to be, elevated. Okay, but the most important thing is the timing. Okay, so what are you looking for? You're going to see increase in serum creatinine, okay, by 0.3 in 48 hours, or 1.5 higher than the normal base in 7 days. Okay, these are the definition of acute kidney injury that you must know. Okay, I'm not going to go into depth about that. That's just straightforward. Okay, so when it comes to acute kidney injury, the good thing about acute kidney injury is that they are reversible, which is great. It's perfect. They're reversible. Just find out what's causing the problem, boom, and that'll be reversed. All right, and I'll go through that in a minute. Again, do you have to notice? 100%. The staging of AKI, stage 1, stage 2, stage 3. Make sure you know that. Again, I can't teach you that. Just pure memorization. But the main thing you have to remember is the timing. Okay, within 7 days, within 48 hours. Okay, those are the things you're looking for. And clinically, you're going to see azotemia, increase BUN, creatinine. You're going to see low urine output called oliguria, and obviously your GFR is going to reduce. But know your staging. Okay, all right. Good. The next I wanted to talk about might be another issue on the exam. I want to make sure I clarify this. So give me a minute. This is acting up. I'm gonna move these things my way. I can't move it. Jeez. Anyway, so the next thing is this thing is in my way.
Are
Sorry.
you trying to move your toolbar? Doug?
Yeah, it's killing me.
So go up into the, okay, go to.
I got it. Done.
Go to
Done.
more and then remove the floating.
Yeah, I got it. Thank you. Right. So basically, with AKI, basically you have the pre-renal, you have the and the post-renal. The pre-renal is anything before the kidney. So anything that affects, okay, or anything that could cause AKI before the kidney. So for example, if I have a blood clot, okay, on this renal vessel right here, okay, that's before the kidney. That's pre-renal. If I have sepsis, okay, causing dehydration, okay, that is, okay, pre-renal. If I have a blood loss, okay, that's anything before the kidney, okay, is called pre-renal. What is the number one cause of pre-renal AKI?
Like low volume.
That's right. Low volume. That's it. Hypovolemia. Low volume. Okay. Why is not working now? There you go. Low volume. Okay. So most is the most common of the AKI. Okay. Your pre-renal is the most common. And obviously what's really going on is just low volume, hypovolemia. Okay. So, and basically if you have a low volume, how do you treat low volume?
Do things to increase the volume.
Give them some fluid.
Fluids,
So basically with your pre-renal, give them some nice fluid. Okay. Patient is septic, give him some fluid. Patient is having blood loss, give him some fluid, or blood, give him some blood transfusion and some fluid. Patient is dehydrated, give him some fluid. Okay. Vascular occlusion, again, when you have renal stenosis or a blood clot, okay, before the kidney, okay. Obviously you want to, remove the clot and give him some fluid. Okay. So fluid. That's how you treat pre-renal. Okay.
Is that lactate ringer that he spoke about? Is the fluid supplementation?
Yeah, you could use lactate ringer. From my experience though, when I was a resident in ICU, we use a lot of amoxicillin for these people. Okay. But you could use also LR, which is lactate ringer, 100%. Renal, with the renal, basically anything that is affecting the kidney itself, so what is the number one cause of renal AKI?
Diabetic neuropathy? No?
Infection?
Acute tubular necrosis.
Acute tubular necrosis, he said it, and also it's in his handout. Acute tubular necrosis, number one. Okay, number two is
NSAIDs.
nephrogenic medications, your NSAID, vancomycin, the combination of vancomycin and zosyn, aminoglycosides. Okay, so that's your number two. But number one is acute tubular necrosis. So when it comes to post-renal, is anything after the kidney. Okay, so if they mention something like BPH, prostate cancer, I don't know, cervical cancer, anything after, that's called post-renal. And what's the best treatment for post-renal?
Remove.
Best treatment.
Catheter.
Yes, you want to drain it. You want to drain and put it in a catheter. Anyway, the number one cause is BPH, followed by stone tumors. And obviously, you want to find out what's causing the problem, then put a catheter and treat the problem. Anyway, so I wanted to focus on that. So I just discussed pre-renal. Okay, it's the most common type of AKI. Okay, obviously the causes we talked about: hypovolemia, increased vascular capacity and leakiness caused by sepsis. You could also have renal stenosis due to atherosclerotic plaque. or blood clot, anything that could prevent blood going to the kidney is your pre-renal, and the best treatment is the fluid. Intrarenal, the number one cause is acute tubular necrosis, and number two is your nephrogenic medications. You want to make sure you remove those stuff, okay? And basically with nephrogenic, the best way to treat them obviously is to remove the offending problem, okay? And this is from the slide. The most common is your acute tubular necrosis. Intrinsic tubular disease is also called your intrarenal disease. Okay, intrarenal disease. Okay. Keep going. Post-renal. With post-renal, again, what's really happened is that anything after the kidney. So urethra, ureter, your bladder, your cervix, any problem within that area that causes obstruction, and causing the backup of fluid into the kidney. That's your post-renal. There is something called hydronephrosis. Hydronephrosis, actually, most of them are caused by post-renal, where pretty much caused by intrarenal too, but most of them are caused by post-renal. So what happens is that you have fluid backing up into the kidney and cause the kidney to swell, and that's where you're going to see this big-looking kidney hydronephrosis. Okay. And I'm going to keep going. The best way to diagnose post-renal is to do ultrasound, which we talked about. Okay. Another thing that's very important that you should know is that what do you see, with the blood work and urinalysis with pre-renal, post-renal, and intrarenal. Okay. With pre-renal, okay, you're going to have increase or decrease BUN. Anyone?
Increased.
That's right. And the reason why that is because when it comes to pre-renal, there is no problem, right? There's no problem at all with the kidney. The problem is that, there's not enough blood getting there, or there's not enough fluid getting there. So basically, you're going to have a low GFR. Because at low GFR, you're going to have increased BUN. Your creatinine is going to stay the same, but your BUN is going to be extremely elevated. And also, there's going to be reabsorption of the BUN, within, PCT. So in pre-renal, you're going to have increased BUN to creatinine ratio. Okay, it's very important. Then the next thing that's going to happen is that the body is going to compensate for that and say, wait a minute, I don't have enough fluid anymore. I'm losing all my fluid. Okay, which is the problem with pre-renal. I don't have enough fluid. So the body will activate the RAS system, right? The renin-angiotensin-aldosterone system. And once that happens, what you will see in pre-renal is that you're going to see increased serum sodium. You're going to see increased water. Okay, you're going to have a decrease urine sodium. If you have a decreased urine sodium, then you're going to have your urine will have high osmolality. Okay. Any questions about that? Okay.
Sorry, could you just repeat that? I think I missed something.
I don't want to repeat everything. Tell me what I need to repeat.
So you said there's going to be increased osmolarity, right?
Why?
Just like the last few sentences you made.
Okay, so what I'm saying with pre-renal, what's happened is that you have less fluid within the body. Okay, there's gyrations, low volume. So when we have low volume, right, the RAS system will be activated. When the RAS system is activated, it's going to make sure we reabsorb sodium. When you reabsorb sodium, guess what's going to follow it? Water is going to follow it, right? So if water and sodium, okay, is going to the body, what's going to happen to the level of sodium in the urine, right? It's going to be low, okay? So if that's low, what's going to happen is that means there's not going to be enough water going out into the kidney anymore and out into the urine. Then you're going to have increased osmolarity. Remember, I said osmolarity, you have increased concentration within the urine. So your urine will be concentrated in pre-renal.
Thank you.
But the activation of the RAS system is a compensatory, right? To try to retrieve any fluid that has made it outside to get it back into the kidney, correct? Because you're not perfusing, you can't get it from its normal, coming from the normal direction. Is
That's
that-
true.
Okay.
Yep, that's true. And when it comes to the labs for prerenal, you have to look at it as compensation, and that will give you your answers. And I'll go into that in a minute. Intrarenal. So everything you know about prerenal is opposite in intrarenal. So that means if your BUN is high in prerenal, in intrarenal is low. If your serum is high in prerenal, is low in intrarenal. So just know, I'll just recommend you should know the prerenal, and everything is opposite for intrarenal. That's the way I remember this. Okay. Then when it comes to post-renal AKI, the initial or the early signs of post-renal AKI look exactly like prerenal. And the late stage of post-renal look like your intrarenal. Okay, so that's what you have to remember. So what I always recommend is just remember this prerenal, and this is opposite, and this right is just initial. Find out if it's initial or late, and if it's initial, it's prerenal, and if it's later, it's going to be intrarenal. Now let's do this together. When you have a prerenal, okay, the serum sodium will be increased or decreased.
Decrease.
Anyone?
Increased.
Why? You're right. Well, to increase
Because
your
we depleted a volume.
right, their volume is depleted. Okay, so what's going to happen? The RAS system will be activated. It will bring in more sodium into the body. When where sodium goes, so water follows to increase the body's volume. So anytime you see your prerenal, again, think about your RAS system, because again, the first thing I have to think about is when you say prerenal, think of dehydration. I'm dehydrated, or I have low volume. Okay, if I have low volume, the RAS system will kick in and we'll take it from there. So if the RAS system kicks in, okay, your serum sodium, okay, will be increased. Okay, in prerenal, okay, what will happen to the urine sodium is going to be decreased. Okay, what will happen to the urinary osmolarity, means concentration, is going to be increased. Okay, remember we said the BUN to creatinine is going to be 20:1. Okay, and there's this thing called FeNO, okay, which was explained in class. It's a calculation. The FeNO is less than 1%, in prerenal, but in intrarenal is more than 2%. All right. Anybody confused about this? Are we good?
Yep.
Okay. So again, this is from his lecture. Okay. Obviously specific gravity, just again, I'll just recommend know the prerenal because the gravity is more than 1. But the most important you want to look for is urinary osmolarity. Okay. It's more than 500. Remember that 300? It's more than 500. Okay. That means concentrated. The urine sodium is going to be low. Okay. FeNO is going to be less than 1%. Okay. But the BUN, nitrogen creatinine, is going to be more than 20. Okay. Now with prerenal, there's no problem with the kidney. Okay. So the urinalysis is normal. But when it comes to your intrarenal, okay, problem, or your intrinsic renal problem, you're going to have a positive protein, you're going to have a positive blood, you're going to have a positive cast. Okay. When you see cast, think of intrarenal or intrinsic. Any questions so far? Okay. With the prerenal, there are medications actually that could cause dehydration, which includes your your NSAIDs, your ACE inhibitor. My question is, why ACE inhibitor? How come ACE inhibitor will cause pre-renal problem?
Decreased blood pressure.
I know. Ow.
It like inhibits the RAS system.
Thank you. Jeez. Who said that?
Taylor.
Taylor. Good. Guys, remember, the ACE inhibitor blocks what? Angiotensin 2. What is the function of the angiotensin 2? Remember, angiotensin 2.
Vasoconstriction.
Right. And it reabsorbs water and sodium at the proximal convoluted tubules. You guys remember that? Yes?
Yes.
Yeah,
Yes.
exactly. So guess what? If you have this ACE inhibitor that's blocking that action, guess what's going to happen? You are not going to be getting water in and getting sodium in. And that's why your ACE inhibitor could lead to pre-renal. Okay. And nephrotoxic medication, okay, that could lead to your intrarenal or pre-renal. What do you guys think?
Intra.
Intra, exactly. If I have a very huge prostate, that could lead to intra or post.
Post.
Okay. How do you
Dr.
treat?
Sam?
Yes.
Sorry, why did you say NSAIDs causes pre-renal?
So, and said actually, for example, if you have, when you have aspirin competes for water, at the proximal convoluted tubules. So that's the reason why when you take NSAID, you want to drink a lot of water, okay, to really flush it out. It's going to compete for absorption of water. That's the reason why. I didn't say it. That's in the slide.
Thank you.
That's the explanation.
Thank you so
Yeah.
much.
By the way, this is why I hate recording this, because this is not my slide. This is not my slide. I'm just explaining. We're pretty much studying together, pretty much. So I don't want to claim, oh, they're not my slide. This is from your PowerPoint. I'm just kind of going over it. Okay, pre-renal, how do you treat it? Okay, crystalloid, when you're losing blood. The best one that I use in ICU is normal saline, and lateral ringer, you can use that too. When it comes to intrinsic AKI, you want to remove the offending problem. If it comes to post-renal Foley catheter, and with the BPH, give them some medication, Thompsonosin, to relieve the BPH or whatever you could use. Just make sure if it's a cancer or tumor, remove the tumor. Okay, you have a patient that is going for BKA, and they have a BUN of 8, creatinine of that. One day after the procedure, BUN shot up, and the creatinine went to 1.3, and you could know this is 1 day later within 24 hours. So you notice that there's an increase in BUN creatinine. That's your azotemia, okay, within 24 hours. So basically, you are dealing with AKI. That's when you look at it. Then in 2 days, boom, it shot up again. Again, AKI is shooting up. Okay. True or false? A patient with elevated BUN and creatinine for 1 month is considered a chronic kidney disease.
False.
Why?
It's supposed to be 3 months.
God bless you. God bless you. That's exactly what I want for this exam. Think. Who said that? Let me give you kudos. Who said that?
Mustafa.
Mustafa, long time no see. Come say hello. I haven't seen you in a long time.
God willing. Yeah, soon.
All right, great. Thank you, Mustafa. So again, just know the definition. Okay. I'm gonna skip this. We know this already. I'm gonna skip that. Hydronephrosis. Okay. Skip that. What is this? What am I trying to say here? What am I trying to say? I don't know. Okay. BPH, we talked about that. Okay, let's do some questions. These are not my slides. Again, I'm just trying to teach. These are not my slide. I want to get in trouble. That's why I hate recording. These are my slides, not my slides. So let's do this together. Which of the following is true? Acute tubular necrosis will be classified as pre-renal AKI high. True or false?
False.
False.
That's right. Creatinine comes from breakdown of amino acids. False. Muscle. Urea is converted to ammonia by the liver. True or false? Come on. False. Ammonia is converted to urea. Okay, ammonia is converted to urea. So by the liver. So that's false. BUN, the ratio of BUN and creatinine tend to be higher in pre-renal AKI.
True.
That's right. Next one, true or false? Kidney failure as a complication from severe burn will potentially bring about pre-renal AKI.
True.
Everybody agree or disagree?
Agree.
Trimethoprim will tend to decrease serum creatinine level. The answer is false. Vancomycin would do that. Aminoglycoside would do that, but trimethoprim does not. Okay, serum creatinine level tend to be lower for female as compared to males.
That's true because they have less muscle mass
That is true. With
most of the time.
Yeah, with intrarenal AKI, urinary sodium tend to be higher as compared to urinary sodium level with prerenal. Any questions? The last one, why is that correct? Anyone?
Because you're not reabsorbing the sodium, and that's why it's above 2% for the intrarenal.
Okay. And again, the way I remember this is just I always stick with my prerenal. With my prerenal, my RAS system is working. If my RAS is working, my RAS is absorbing sodium. If my RAS is absorbing sodium, guess what's going to happen to urinary sodium? It's going to be low. So that means if this urinary sodium is low in prerenal, is the opposite in intrarenal. So guess what? The answer is correct.
Isn't also another way to think of it is like intrarenal, you have kidney damage, so the kidney is not going to be processing as it normally should. So then, unless it's completely just a mess and everything's just flowing straight through like your albumin, and otherwise, the ions would be higher. Is that?
That's the best way to explain it, Jill. You're 100% correct. All right. You're right. With prerenal, what's happening to the kidney is not the problem. Okay. But intrarenal kidney is a problem. So the kidney is a problem. So what's happening is that, your filtration is pretty much affected. So you're going to have, a higher urinary sodium. Okay. You're 100% correct. Which is the reason BUN goes up more than creatinine in prerenal? Okay, we talked about this already. CKD, again, definition is more than 3 months of AKI. Then the next you're looking for is your, albuminuria, okay, hematuria, proteinuria, okay, and obviously you're going to have a low GFR of less than 60. When it comes to CKD, there is, I think, staging, staging of CKD. They have the G1, G2, G3, 3A, 3B. Which one is this one? Less than 60. The GFR is less than 60. Anyone?
Isn't it like, no?
Anyone? What's the answer?
It's 3.
Wrong.
No, it's
If
2,
if
right?
you leave the chart up, I could tell you.
You're below, yeah. You're below, you said 60, right? If it was,
Yeah, that's the definition. Less than 60.
Yeah.
What's the answer?
Isn't it 3A? Because it's 45.
That's right.
59.
You said G3. It's G3A. Okay. Make sure you know your classification for AKI, okay, and your classification CKD in terms of albuminuria and also in terms of GFR. Okay, but again, know this definition of CKD. Okay, what is the number one cause of CKD? The risk factor, number one.
Diabetes.
Okay,
So you want us to memorize the classification?
I want you to memorize classification. If you don't know about now, we got a problem. You better know everything.
I know it
Okay.
all.
You better know everything. You know, CKD, again, you can see it right here. Your number one is your diabetes. Your number two is your hypertension. Okay. So one of the biggest things that happens when you have a CKD is that, you're going to have hyperkalemia, and I'll discuss that in a minute. So you're going to have hypokalemia, anemia due to problem with erythropoietin. You're going to have uremic toxin, uremic pericarditis. So all this you have to know, okay, and how to treat them. So if you have a patient who's got hyperkalemia, how do you treat that? Let's go. Come on.
Insulin?
Come on. What is it?
Insulin?
Yeah, you can use insulin. That, thank God. Yeah, insulin. Yes. What else?
Calcium gluconate.
Great answer. But calcium gluconate does not help you reduce the hyperkalemia, right? You want to reduce the hyperkalemia. Calcium gluconate, what it does when you have hyperkalemia, that will cause excitement of the heart. So the calcium gluconate will calm down the heart. So calcium gluconate is not to treat hyperkalemia to reduce the number of the potassium, but is used to calm down the excitement of the heart. So you have to be careful with that. Okay, it depends what they're asking you. If they say patient has hypokalemia and they have excitement of the heart, what is the best treatment? Then the best treatment is calcium gluconate. Okay, if I'm asking you what can I use to reduce, okay, hyperkalemia, yeah, somebody got it. Insulin. There's something else. There's two other things you could use.
Sodium, zirconium.
Right, that's right. So zirconium, what's number 3? Number 1 is insulin, so zirconium is number 2. What's number 3? Pachyroma, that's right. There's number 4, called K-oxalate. K-oxalate. When you have a patient that's got anemia, how can you treat the anemia?
Blood transfusion?
EPO.
EPO. Thank you, EPO. Okay, good. Okay, you guys remember this? When you have a hyperkalemia peaked, remember the ST elevation? Okay. Keep going. Right. So I want to get to this. Let me see another one. I'm gonna get to another one. There's another one here that I think I have. I'll go back to that in a minute. Hey, I want to use this one. So this is what I was talking about. We're answer that question. So when we have hyperkalemia, right? Hyperkalemia, the first thing you want to do is you want to give them calcium gluconate. Okay, and you want to do that because you want to protect the heart. Again, excitement. Okay, but if you really want to reduce the hyperkalemia, you want to give them insulin plus glucose together. Insulin and glucose, and that insulin is going to shift that potassium to the cell. You have to remember with hyperkalemia, you're going to have metabolic acidosis, so you want to give them sodium bicarbonate. Okay. Dialysis could help you remove your potassium, but you never start with dialysis. Dialysis is the last thing you want to do when it comes to hypokalemia. That's the last thing you do. Okay. Basically, you want to give them, where's my son? You want to give them sodium zirconium called leukemia. You want to give them pachyroma, okay? Or you want to give them insulin, or you want to give them K-oxalate, or you want to do dialysis? We'll go back here. So calcium is 4. We discussed that. Bicarbonate is 4. We discussed that. To lower, the potassium, you want to give them K-oxalate, sodium zirconium, which is called lucuma, or patiroma, or you do dialysis. What is this thing? Oh, so when you wanted to slow down the progression of CKD, right? You want to give them an ACE inhibitor or your herbs to decrease proteinuria, okay? Especially in your diabetic patients, right? Look at this medication again. They keep on following us, right? Your sodium glucose cotransporter 2 inhibitor or your GLP, okay, GLT1. Those two could be used also to help you, okay, reduce the progression of your kidney disease. Obviously, everything else. We discussed that already. Okay. If I have a patient, right, that has creatinine of 1 million, okay, and they have a BUN of 10 billion, okay, and their GFR is 0, right, and they have no symptoms, okay, should I start dialysis?
No.
No.
Oh, you guys are the smartest. Good job. That's right. So if they have everything, which I'll go into depth in a minute. So basically, what would indicate a person to need that urgent dialysis, confusion, seizure, uremic, everything that's listed here, right? With symptoms. Okay, obviously if you're confused, that's the symptoms, seizure symptoms, Hypokalemia itself. Can I use that to dialyze a patient? Just by itself, patient is hypokalemic, right? Symptoms. Again, with hypokalemia, you want to make sure that you've given everything, nothing's working, then you want to fix that. Same thing. And what I'm trying to say is that you want to make sure that there's no symptoms, you don't do dialysis, you try everything first. If nothing is working, then obviously go to dialysis. Okay. So with CKD, okay, most of the time these people have history of diabetes and hypertension. You're gonna see urinary casts. Okay, you're gonna have low protein. Well, you treat them low protein diet, ACE inhibitor, control their sugar and your blood pressure. AKI, okay, you gotta find exactly what's causing the problem and go from there. Polycystic kidney disease. You guys know this already. Autosomal dominant. Okay, and the gene problem is PKD1 and 2 genes. Okay. The biggest problem with polycystic kidney disease is that kidney is so enlarged, it's ridiculous, right? And they will develop hypertension, hematuria, okay, renal failure, okay, which is what's right here. Hypertension, hematuria, proteinuria, okay, and impaired kidney function. Again, this is an ultrasound showing your polycystic, you see this multiple cysts. And obviously, how you treat it? Treat the symptoms. Hypertension, you give them that. Give them some sodium restrictions, increase some fluid on them. And most of the time, they end up with dialysis and renal transplant. Nephrotic syndrome is caused by hypertension. Nephrotic syndrome is caused by increased protein in urine. You should know that. Nephrolithiasis, kidney stone. How do you treat that? Kidney stones. Anyone?
Laser ablation.
Oh, pain medication, IV fluid.
Yeah, because first you try to help them pass it, right? And then
That's right. That's right. Yeah, we want to help them pass it. Okay, I'm done with nephrology. Any questions about that? You guys are quiet. Did you study? Did you guys
We
study?
studied so much we don't have questions.
Okay, good. Okay, I'll take that. That's good. Excellent. So I want to go to geriatrics. I think this is pretty straightforward. But I want to cover some stuff, and that I think is important. It's a little confusing. Just kind of clarify, and the rest of them just gotta go finish your studying and just study everything else. Why is it not working? Okay. Okay. What is the difference? Actually, let me start here. Let me go back. Good. What is delirium and what is dementia? What's the difference between them?
Delirium is reversible. Dementia is not.
Good. What is the difference between dementia and mild cognitive impairment?
Dementia is like your daily life activities are like inhibited. Mild cognitive impairment, they're not.
Wow, you're on fire. Anthony, good job. I love it.
Thank you.
So, Anthony, I'll stay with you. Dementia and Alzheimer, what's the difference?
I just know Alzheimer's is like the absolute late stage version of dementia, but I don't have a better like explanation than that.
You got it. You
Oh, okay.
got it. Okay, so basically, dementia is an acute state of confusion that is reversible. Okay, with dementia, what am I talking about? Delirium. Sorry, delirium is an acute state of confusion which is reversible. Okay, so reversible dementia. This is the number one problem actually with elderly when they get to the hospital. They put them on medication, especially morphines and other sedatives or other medication or polypharmacy, and it's causing confusion. Okay, so one of the best you want to do for delirium, actually, you want to find out the offending problem and just remove it. If it's a medication, stop the medication, right? So delirium just a sort of confusion, which is reversible, okay? Whereby your mild cognitive impairment is kind of the same thing as dementia, except for these people actually function properly. It just that they tend to, forget things easily, so a 17-year-old forgetting things easily, but still functioning properly. Okay, that's your mild cognitive impairment. When it comes to dementia, okay, dementia is pretty much irreversible, state of confusion, okay, which is chronic, loss of memory, and other problems that could affect the daily function. Whereby your Alzheimer's is a form of dementia. And pretty much the definition is when you have an MMSE score below 24, that is definitely a diagnosis for your Alzheimer's or for dementia. And basically, these people have memory loss, and having difficulty finding their words and difficulty in dressing and all that stuff. So basically, dementia and delirium. Delirium again is acute. We talked about that already. About dementia. Dementia is insidious. Okay, and actually, these people they lose function. These people, is acute, which is reversible. They also lose function. They lose their function. Delirium lose their function. Dementia lose their function. This is reversible. This one is not. Come on. I gave the answers. I thought I. Okay. So basically, what opioid analgesics should you be avoided? It should be avoided in people with delirium, with pyridine. Okay, that's again. I'm just reading it. I think that's from the PowerPoints. Okay, which is better in controlling delirium? If you guys remember in your exam 1, okay, in IMED 2, when it comes to this psychotic or psychiatric condition, basically the first you want to do is to do a behavioral management, behavioral therapy. If that's not working, then you want to go to pharmacology. Never try to start medication first. Don't do medication first. Always behavioral. Okay, so behavioral, if that's not working, then you go to pharmacology. Then, go from there. So basically you want to try not to ever restrain these people. Okay. What is the best way to diagnose delirium? I want to get a really good history and physical. And the best place to get your history and physical, most of these people that are elderly, they are living with their home attendant. So I think the best way to get that history or to get their baseline is to find out from the home attendant, to find out from their family member that live with them. Not a family member that haven't seen them in 10 years. The one that live with them and that know them very well, they could kind of tell you, well, 6 months ago, it's never like this. 2 months ago, it's never like this. But since you got into the hospital, something is wrong. And that's kind of a way to kind of really diagnose the delirium. You need a good history from someone that knows them very well. What is best medication for delirium? Pramiprazole, and for pain, morphine. Okay. Again, this is just literally from your slides. I'm going to skip a lot of this. Just go study. Just go read that. But the one I'm going to focus on is to know what is delirium, and how to really take care of it. One of the biggest problems that you see in ICU or a patient that was admitted, elderly that admitted, is that they'll go into the delirious state because of some kind of medication. So watch out for the medication, elderly. Okay, that's definition. We discussed it already. Medication. I'm trying to get to, again, history and physical, very important. Okay. I'm getting to some. Again, always start with behavioral intervention. Always behavioral intervention. Get a sitter. You don't ever want to restrain these people if you could avoid it. Okay. If you could avoid any medication, like sedatives and anything that would just kind of cause automatic status or cause some confusion, you want to try and get away from that and use behavioral modification or behavioral intervention first. Again, being stressed again. This is not my slide. This is this is hers. Behavioral and pharmacological. You want to start behavioral first, being repeated. Okay. Again, keep saying it. Avoid physical restraint. Avoid pharmacologic. Okay, just keep saying it. All right. Let me see what else. What else? Dementia. Alzheimer's, we discussed that already. Again, the definition of Alzheimer's is dementia is when your MMSE is below 24. You guys know that already. Keep going. All this you can just read. That's simple. I want to discuss things that are very important. Okay, so I wanted to discuss this. So, yes.
I think this is maybe from a previous instructor because these are not the slides from the doctor who taught us. Just side note. This time.
I guess I think it's the same thing. It's the same information, right?
Yeah, but I have to say that the instructor that we had, she basically for delirium, it was like avoid all. She said, like what drugs to avoid, and you really didn't treat them. Maybe if they were kind of like disorderly, there would be very low doses of morphine, but that was about the only drug that she indicated to use. So I don't know if she's writing the questions or not, but just
she's writing the questions. She's writing the questions. And everything she said is obviously she's the author of geriatrics and she's the director of geriatric programs.
I was just so there's no conflict.
No, there's no conflict. I'm saying same thing. We're saying the same thing, right? You're not going to use morphine first, on a patient that's got an issue. You want to try and do behavioral, intervention first, and that's not working. Then you want to give it a little bit of morphine and be cognizant of that. Be careful with it. That's all. It's the same information. Obviously, Minicog, and MMSE. Minicog is faster. Minicog pretty much they have to recall 3 things or 3 items. And if they don't get it right, then you go ahead and attempt to draw, a clock, and from there you could determine if they're demented or not. Obviously the MMSE is more sensitive, more specific, but this is faster. Okay, Let me just make sure. And that's it for that. The rest of them, I mean, Jill was just lecturing me now. That means Jill has been studying very hard. Thank you, Jill. Again, the rest of them just read it. Just go read it. But what I want to discuss is what I think is really important, which is the differences between delirium, dementia, Alzheimer, mild cognitive impairment, and want to make sure that behavioral intervention is more important than using pharmacologic. Stay away from any medication as much as possible with these people, and do not restrain them. Try not to restrain them. The next I want to discuss, which I think is important, is urinary incontinence. There's transient, okay? The transient, basically, I think this was also in the PowerPoint, diapers, right?
Yes, she just described the two different types of incontinence.
Right, so it's the same thing, same thing. So you have the transient, and which is temporary urinary incontinence, and you have the permanent, the persistent. The transient is temporary because it's caused by, when they're admitted into the hospital, something is causing the problem, causing them to have urinary incontinence, which is, delirium, infection, all this other stuff is listed here. Okay. Now, with these people, when they have urinary incontinence, you don't want to put a Foley on them, especially when they come transient incontinence. Do not use a Foley. What you want to do is to find out what is causing this problem and fix that problem as soon as possible. But do not use Foley on these people. The one that I think is very confusing that I want to spend time with is your clinical types of urinary incontinence. We have the urge, we have the stress, we have the mixed, and we have the overflow. Okay, and under the overflow, you have the the outlet obstruction or the destructural underactivity. Okay, so what is the urge? The urge, pretty much what happens is that you have overactivity of the bladder. The bladder is is hyperactive, so that's causing the patient to go to the bathroom a lot. Okay, so you find out these people going to the bathroom a lot, and they say, yeah, I just peed, but it's still, I still feel like it's small, pretty much they always go to the bathroom. Pretty much they make it easy like that. They always go to the bathroom, and that's a urge. Okay, the stress, this is mostly seen in females, mostly seen in females where the pelvic muscle is very weak. So their kidney, except their bladder is fine. There's nothing wrong with their bladder. The problem is just the pelvic muscle. So with these people, the best way to fix their problem is not medication, is to improve the health of the pelvic muscle by doing Kegel exercise. Okay, mix is when you have a combination of urge and stress. That could happen. The last one is called the overflow. The overflow is the opposite of urge. So if you know what an urge is, then the opposite of that is the overflow. So what is causing the urge is the overactivity of the destructural muscle. But when it comes to overflow, okay, also called the outlet obstruction, what's happening is the underactivity or low activity of the destructural muscle. So with this right here, the bladder is contracting a lot, the urge, right? They go to the bathroom a lot. But when it comes to the overflow or the outlet of obstruction, the bladder is not contracting at all, or it's very weak. So what happens is that, you're going to have an increased volume. Water is going to continue to fill, urine is going to continue to fill into the bladder and fill into the bladder. And when it's really, really full, they feel like, I want to go to the bathroom. When they get to the bathroom, they get a little bit of drip, drip, drip. When you get the word drip, 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 I went to the bathroom and I'm just getting like a little bit of drip, drip, drip of urine. It's not much coming out, but I feel like I gotta get to the bathroom all the time. But when I'm in the bathroom, I'm dripping. It's not much fluid coming out. That is your overflow. Okay, that means that the bladder is not really contracting, or the destructural muscle is not really active. Okay, so what we see is that the volume, the void volume in overflow is over 200. Okay, whereby the void volume in urge and stress is less than 200. So basically, how can you diagnose these conditions? You want to do your void test. If it's over 200, you deal with overflow or outlet obstruction. If it's less, you deal with urge or stress, and you got to figure out exactly which one's what. Any questions? Okay, so right here with the urge, basically the muscle is over contracting, and basically you always want to go to the bathroom. With the stress, there's no problem with the bladder. The problem is with the pelvic muscle. You want to make sure you improve the health of the pelvic muscle by doing Kegel triangle, by doing Kegel exercise. Okay.
Dr. Sam, if you could just confirm, you said if it's over 200, it's urge?
Yes. No. Over 200 is overflow.
Oh, that makes sense.
Less than that is urge or stress.
Okay, thank you.
So if you guys remember this, when it comes to the, receptors, you have the alpha and the beta. The function of the alpha is to, smooth muscle contraction. When it comes to beta, causes smooth muscle relaxation. When it comes to muscarinic receptors, what they do actually is to cause contraction. So muscarinic receptors or medications will contract the muscle, will contract the bladder. Okay, make sure you remember that. Okay, let's keep going. So for example, if I have a patient, okay, that's got a urge incontinence, right? Should I give them muscarinic medication or anti-muscarinic medication?
Anti-muscarinic.
Exactly, because again, what's happening? They're overcontract. So you want to reduce that. You want to give anti-muscarinic. When it overflows, should I give them muscarinic or anti-muscarinic?
Muscarinic.
Exactly. That's what you want to know about that. Let's keep going. Okay, so when it comes to urge is the most common in elderly, the most common in all elderly, male or female. Second in female is stress, and overflow is common in men. So let's do a quick exercise. What is the most common urinary incontinence, persistent urinary incontinence in men?
Urge.
What is the most common urinary incontinence in women?
Urge.
Good job. Urge. So urge is the most common in all elderly. Okay, what is the second most common in men?
Overflow.
What about in women? Are we good? Yes?
Yes.
Okay. So that's kind of like the main thing I want to cover here. The rest of them just straightforward. So I'm not going to go into depth about that. Oh, this is very important. Let me do this real quick. Sorry, guys. Sorry. I forget. A patient that has urge incontinence, right? Can I give him diuretic?
I wouldn't.
Wouldn't.
Good. All right. So that's it for that. This is what I was talking about. Okay. Your void test. Okay. Post void residual. Okay. So basically, if it's over 200, okay, you call PVR, your post void residual. If over 200, that's your outflow or outflow obstruction or overflow obstruction. And if it's less than that, it's your stress or urge. Okay, again, remember, keep on talking about this with the psychiatry, now with geriatrics, okay, lifestyle modification, behavioral, don't do drugs. This is the best too. Stay away from this, stay away from that. If you can't control it with this, then you're going to go to drug. Be careful with the drug, because that causes delirium. Okay. Okay. See, that's it. Any questions about that?
Sorry.
I'm trying to finish this as soon as possible so you guys go and sleep. So I'm rushing a little bit. Let me just make sure we are here. Any questions so far? Are we good? We're good, right? Good. We are good. We are very good. We are very good. Can you guess what I'm sharing?
Yeah.
Okay. Okay. So basically, the slide she gave you guys again, is similar to this. But again, I want to cover what I think is very important. The rest I'm just reading. Just read it. Okay. So BPH, we know what it is already. BPH, will it cause pre-renal, intra-renal, or post-renal?
Post-renal.
All right, post-renal, right? How do you treat BPH?
Prazosin.
What? Okay. That's it. That's what I want to talk about that. Your alpha 1 antagonists, okay, or your alpha blockers. Make sure you know that. Okay. What else is here? Am I forgetting anything? So the next one is fall. Okay. So can you tell me things that could lead to a patient falling, elderly falling?
Poor footwear.
Impaired proprioception.
Okay, keep going.
Vacation.
Medication, keep going.
Squishy shoes.
That's right, keep going.
Vertigo.
Visual problem, keep going.
Clutter.
Do they have increased muscle mass or decreased muscle mass? Are they?
Sarcopenia.
Sarcopenia.
Exactly. Good job. So you got this. Medication. Okay. Your sedative use. Remember, we talked about that in the first geriatric lecture. Sedative, you want to stay away from there. Okay. That could cause a fall in these people. So a lot of places cause fall. So you just have to know that. You know that already. Okay. What else? Just know your medication that cause fall and condition that can lead to fall. How can you do fall prevention in adults? Just read up on that. Shoe wear. You want to make sure your shoe is good. Your vision is better. Stay away from sedatives. Walkers to prevent fall. As you age, you're gonna get more muscle mass. True or false?
False.
False.
As you age, you're gonna get more fat. True or false?
True.
As you age, you're gonna get more water.
False.
Good. So we just discussed all that. Sorry, I want to make sure. That's it. The another thing I didn't cover here is all definition, like, when it comes to ASPIS, what exactly is that? What is, advanced directive, all that stuff, again, is very straightforward. FCare proxy, you guys know that already. Just go review that and read it. It's very straightforward. I'm not going to go into depth about that. So let me go to the last one. This is the one that I think you guys going to struggle with. Endocrine and woman health. Those are the two tough ones on the exam, and I'm just being honest. So I recommend, if you don't understand anything at all, spend a lot of time making sure you understand your endocrine very well, understand your woman health very well. Nephrology is very straightforward. Geriatrics very straightforward. The problem, I think, personally, is going to be women health and endocrine. So I'm going to spend the next 15 minutes going over this real quick, and hopefully I could do a great job. Okay. Let me keep going. What is this thing? What is this thing saying? Oh yeah, know your definitions. Okay, you know definition. You know what is amenorrhea. What exactly is that? What's primary? What's secondary? So you should know that. Okay. Obviously, you want to know if the patient is primary. What makes them primary? If the patient is secondary, what makes them secondary? For you to go to secondary, you have to walk them up. And you walk them up. You want to find out if they have a uterus, if they have
Uterus.
Development.
I don't want to say this. What's a better word to use? Okay, sorry. Oh,
Yep.
my goodness.
Is that what you're trying to
Say
get?
again?
That are you trying to get your reproductive organs? You're just having a hard time saying vagina or something?
Whatever. Right. Uterus, vagina, fine, breast. You want to make sure that, all these three, are present. Okay. So for example, uterus, if it's present, vagina is present, breast present, then you want to walk them up for secondary, amenorrhea. But
Dr.
if,
Sam,
yes.
do you mean to share your screen? We can't see your screen.
Oh, you can. Oh, I'm sorry. Oh, geez. 1 minute. Share my screen. How about now?
Yeah, thank you.
This is so. Swear to God, this thing is so annoying. Give me 1 minute. Finally, I do better on this. Give me 1 minute. Okay. All right. This is what I'm talking about. This is what I'm looking at. You need to know this very well. Okay. If they have uterus, vagina, and also breast. Okay. If all that is present, okay, and they having amenorrhea, that means it's secondary. Okay, that's what that means. If it's absent, they could be, your TFS, or your MRKH. Again, this is just pure memorization, unfortunately, just pure memorization. But the most important thing is that once they have uterus, vagina, and breast, which will say on the question stem, they have this, that. So if they have all that, then that's kind of pushing towards secondary. If they don't have it, then that's probably primary amenorrhea. You got to find out exactly what's causing it. What could it be? It could be this, it could be this, it could be that. Okay. So when you have a secondary amenorrhea, okay, know the definition: the absence of menses, for 3 cycles, or absent for 6 months. Okay, for someone that's had a menses before. So that's your secondary amenorrhea. So what could be causing that? Everything is listed here. Everything that could be causing it. And the best way to find out, if this is due to low estrogen or progesterone, you could do estrogen test or progesterone challenge test. Okay. So the first one to start with is your progesterone challenge test, because when you do a progesterone challenge test, once you stop the progesterone is going to cause the release of blood. It's going to break down the endometrium. Okay, and if you do estrogen test, that will kind of help you with ovulation. Okay, so progesterone test, if it's positive, okay, and they have Archwit, okay, that means they have air, in their body. It could be polycystic ovarian syndrome, or it could be ovarian or adrenal tumor. Okay, so my recommendation is that anytime you see, altruism, okay, especially in female, think of PCOS. Okay, and the first you want to do on this patient, and all patients, by the way, all patients that are female, the first you want to do is to do a pregnancy test. Okay, urine or blood, it doesn't matter. The first you want to do is to do a pregnancy test. Pregnancy test comes first before anything. And I'll discuss that. I mean, they discussed that also in the PowerPoint. So do a pregnancy test. Okay. And if they have hair, they're very hairy, you want to do a testosterone level. Okay. Anytime you see a female present with an hairy body, pregnancy test followed by testosterone. And I'll discuss that in a minute. Okay. So anyway, if they have Ullrich, then it's probably, PCOS or ovarian adenoma. And if they do not, it could be your hypothalamic dysfunction. If you do progestin tests again will induce messes. And if you do progestin test and it's still negative, it could be that they have something called Asherman syndrome. Asherman syndrome is pretty much just, what's going on is that, the ovary is functioning properly. Okay. The uterus is beautiful. Nothing is wrong with the structure itself of the uterus, but it's a lot of scar tissue that is preventing ovulation, or not prevent ovulation, but prevent egg from getting to uterus. And also, there's a lot of scar tissue that's causing the prevention of breakdown, of the endometrium. Okay, that's called the Asherman syndrome. Okay, so if it's negative, rule out Asherman syndrome. Okay, and the best way to rule out, just kind of look at it. Look and see if there's any scars in there. If the Asherman syndrome is ruled out, is not, then the next you want to do, FSH, follicle stimulating hormone. If it's above 40, then it's ovarian failure. And if it's below 40, is your hypothalamic dysfunction. Again, this is everything they talked about. I just wanted to kind of explain that. This you have to know. I think this I think that's going to cause you a problem on the exam. I really think so. Know this slide very well and know that slide very well. Any questions so far? Okay, so let's go to the next slide. So there is something called, women with withdrawal bleeding. Withdrawal bleeding is pretty much what that means is you do a progesterone test, and when you do that, you want to make sure they ovulate. We want to make sure they bleed. It's going to induce menstrual period. Okay, so a positive withdrawal bleeding is it's a good thing. That means that the endometrial wall is okay. Okay, so if a patient bleeds, okay, it could be that they have a lack of ovulation, but the wall is fine. So the reason why they're not ovulating is because the wall is fine, but they have other issues causing the ovulation not to come. It could be that the ovary is something's wrong with the ovary. Okay, I don't know what happened there. What just happened there? Something wrong with the ovary, or it could be polycystic ovarian disease. So anytime you do a progesterone test and you see bleeding, remember this slide, when it's positive, PCOS, polycystic ovarian syndrome, most of the time. Now, women without bleeding, you give them progesterone tests, okay, and there's no bleeding, okay? Progesterone tests and there's no bleeding. Think of the Asherman syndrome. There's a scar within the uterus, okay? That's number one, okay? What I'm trying to say, if it's positive, think of, polycystic ovarian syndrome. If it's negative, rule out Asherman syndrome, okay? And that's what you have to know about this. This is what I'm talking about that is very important. This slide is huge. When you have secondary amenorrhea, the first thing you have to do is to get your pregnancy test. Okay? It doesn't matter what's going on with that patient. Anytime you see a female, pregnancy test. Okay? If that pregnancy test is positive, then they're pregnant. That's what's going on. That's why they're not seeing their misses. Right? If it's negative, then you got to find out, okay, where is the problem? Now, this is where I want to help you out to make sure you don't mess up. Okay, when it comes to a patient that is airy, they have air in their back, in their body, very airy, their face, the next test you want to do after your your pregnancy test is a testosterone for people that are hairy, because you're trying to rule out your polycystic ovarian syndrome. Okay, always do that first if you see hair. If it's not hairy, on the stem of the question, patient is very hairy, nothing is that's not there. The next you want to go for, okay, is to do your FSH. So first one you're looking for is, are they hairy or not? If they're not hairy, don't even worry about the testosterone. Forget it. Don't worry about it. Okay. Then the next you're going to go for is FSH to find out if they have a primary ovarian insufficiency. So that's your number 2. The next one you will write in tumor, which is prolactin. Okay, prolactin, or your prolactin. Okay, and the next one to rule out, hypothyroidism. So let me stop here to make sure we are on the same page. Any questions about that? Are we good? Yep. No confusion, right? Okay, good. So another thing that I think is important here, this might be a little confusing also, polycystic ovarian syndrome, is that, again, is the most common cause of female altruism. Okay. All right. So when you see that, you want to order your testosterone, very important, okay, on these people. Now, when it comes to polycystic ovarian syndrome, you're going to see obesity, altruism, they have amenorrhea, they have infertility, they have acne. Most importantly, they have diabetes and insulin resistance. Okay. And basically to diagnose these people, obviously, you want to see if they're ovulating. If they're not ovulating at all, boom, that can give it to you. If they have hyperandrogenism, okay, meaning that you have elevated right there testosterone. So when you see polycystic ovarian syndrome and they have a hairy body, you want to order your testosterone first, followed by your FSH. Okay, then obviously when the ultrasounds kind of rule out, polycystic ovarian syndrome. All right. Obviously, you want to do your glucose tolerance test to rule out diabetes. Okay. When it comes to treatment, lifestyle modification. All right. If they're infertile, you want to give them, okay, metformin. That will help them with diabetes and also help them out with the ovulation. If they have autism, you want to give them birth control. Okay. Just make sure you remember that, and if they have hypoglycemia, you want to give them metformin. Okay. All right. I need a volunteer. So if I have a patient who's got a polycystic ovarian syndrome with diabetes, what can I give them?
Metformin, birth control.
Yeah. Go back. What's the answer again?
That's not fun.
Metformin. That's it. Nothing else. Metformin. Patient with polycystic ovarian syndrome with autism.
Birth control.
That's right. Patient with polycystic ovarian syndrome with infertility.
Metformin and induced ovulation.
That's right. Are we good? Okay. Always test for pregnancy. Always do the pregnancy test on these people. What's the first hormone you wanted to check on these people with PCOS?
Testosterone.
That's right. What's the answer here? And why? Why?
Because they have hair.
Good. So I want to skip this. This is pretty much straightforward. I'm going to skip that. Endometriosis. I wanted to talk about this real quick. So, when you have endometrial problems, okay, obviously the gold standard, you wanted to, do a biopsy. And I think that's very important is that, people that have a vaginal sex, okay, and they're bleeding out the vaginal sacs, what do you worry about?
Cancer.
Answer.
Cancer. That's right, right. So what's the best answer for these people? We'll do a pap smear and do a biopsy. Okay. Menopause, you guys know what it is already. The definition. I won't go into depth about that. What is the best treatment for menopause?
It depends on if you have a uterus or not, right?
God bless you. That's exactly what I was getting at. So you've been reading. Good job. If they have a uterus, then you want to do estrogen, progesterone. If they do not have uterus, what you want to do?
It's progesterone, correct?
That's right. You got it. What about this patient? They have a very dry vaginal area, very trophic. How do you treat that?
Estrogen cream.
That's right. That's right. This is what I want to this is what I want to talk about. So this is another one that's going to trick you on the exams. I want to break it down for you, okay, to make sure you guys understand this, okay? Because again, the exam is all about making sure you understand the material and putting it together. Don't memorize, understand it. So if you have a patient that has got a ascus, okay, the first you want to do is to do HPV, okay? If the HPV is positive, then you want to do, colposcopy or pap smear with biopsy. Okay. Any questions about that? No question? Good. If your HPV is negative, right, what you want to do is just repeat pap smear every 3 years. Case closed. Right? What if you have a, ascus ×2, meaning it was positive last year and it's positive again? That means you have a very high suspicion for cancer. The next thing you want to do is to bypass HPV and go ahead and do colposcopy and biopsy, right? And if you do colposcopy and biopsy and it comes out to be cancerous, you want to do hysterectomy, okay? So negative pap smear, repeat every 3 years. We know that. Pap smear, plus HPV that is negative, then you want to repeat every 5 years. And that's the rule, for ascus, okay, when it comes to cervical cancer. Any questions? Are we good?
Sorry, Dr. Sam, I was trying to find my mute button. So, frankly, the term ascus has been used over and over, and I've not been able to understand what is ascus, or is that an acronym for something?
It's an acronym for atypical, right here, look, can you see what I'm pointing at? Atypical squamous cell of undetermined significance.
Okay, thank you.
Atypical squamous cell, yeah, okay. Any other question? No, good. What happened here? So what's your diagnosis? I mean, what's your answer? Sorry.
B.
Good. Any questions about that? No? Anybody want to try this one?
Is it C? Because she's postmenopausal, so I thought that bleeding of any kind in a postmenopausal woman is viewed as cancer unless otherwise.
You got it. That's it. Why isn't that E?
Because, that would just be the uterus.
Good job. So you want to do a pap smear and check everything to make sure you're not missing anything. Then you do your endometrial sampling. Good. All right.
Sorry, Dr. Sam.
So let me see. What is this one? I'm going to skip that.
Dr. Sam.
Yes.
Sorry, when do you prescribe
Give me a
topical
minute. I'm sorry. Give me a minute real quick. I'm going to finish this. ovarian cancer. You guys know the gene, right? BRC. That's easy, straightforward. I want to give me a minute. I'm sorry. I'm going to skip this. Okay. Contraceptive. Which one is the most effective and which one is the least effective?
Most
I know
effective is
sterilization.
sterilization,
Yeah,
and then
it's
least
most-
effective is spermicide.
Okay. Good. Okay. What's the question? I'm done. That's it.
Sorry, when do you use topical estrogen cream?
When?
Yeah.
Oh yeah, in people that are are menopausal, they have a low estrogen, so basically, if they have osteoporosis, you could give them some estrogen therapy, or if they have a vaginal atrophy or very dry, vaginal area, they want to give them estrogen cream.
So for that question before that Joe was answering correctly, she mentioned that you have to do a pap smear and then the endometrial biopsy. Why couldn't you give her topical estrogen?
Oh, well, good. Let me go back. Which one is that one? Go back. Which one is it right now?
I think it's this one.
Right. You
So
tell me.
why can't
You tell me. You tell me. The exam is tomorrow. You tell me.
Well, you mentioned that she's postmenopausal, right?
Read it. Read it. Let's read it together. 65-year-old obese female present with vaginal bleeding for 3 months.
Okay, got you. Yeah, 'cause
Okay.
okay, sorry, missed that. Okay, thank you.
No problem. Okay, I want to let you guys go. Do you have any questions for me? I think the exam is going to start at 7:20. And we're gonna finish, I think, 9:10 or something like that. I personally don't think, again, that's for me. I don't think you need the entire time. So starting at 7:30. That's, remember, you have to be there early. Don't miss the exam. So starting at 7:30. If you get that 7:30, is not a bad idea, really. But if you need all your time, get to 7:20. Finish early, then you finish early. Endocrine, again, I said before, it's a lot in there. Women Health is going to get you a lot. You just make sure you pay attention to all the buzzwords, and I hope I was able to help you clarify some of these confusing concepts within endocrine and Women Health and geriatrics. And I want nothing but 100% on the exam tomorrow, and I want to wish you good luck.
We'll
Thank
do
you.
our
Thank you,
best.
Dr.
Thank you, Dr. Sam.
Thanks, Dr. Sam.
Thank you.
Bye.
Thank you.
All right.